Hi, I'm Dorothy Bulis. I'll be discussing Pediatric Gynecological Emergencies evaluation with ultrasound. Today we'll review techniques of ultrasound evaluation of pediatric gynecological emergencies. We'll review differential of pelvic pain at various stages of pediatric life, and we'll discuss the appropriate radiologic workup of the emergencies of the pediatric GYN exam. Appropriate imaging and correct interpretation of gynecological emergencies requires the knowledge of what is normal and what the differential diagnosis is at various stages of pediatric life. We'll discuss the uterine and vaginal congenital abnormalities and tumors, as well as adnexal abnormalities, including cysts, tumors, torsion, and pelvic inflammatory disease. Ultrasound is the predominant imaging for girls with pelvic pain or masses. We can use 5 to 9 megahertz transducers for infants and 3 to 5 megahertz transducers for children and the adolescent. It's important to perform the exam with a filled bladder. With young infants, proper timing and a flexible schedule allows to successfully examine the pelvis without having to catheterize the bladder. At times, water enemas can be useful to rule out pseudomasses or to search for the uterus. The translabial approach can be useful for looking for vaginal outflow obstruction. Transvaginal exams can be used for sexually active teenagers to rule out ectopic pregnancies and tubo-ovarian abscesses. Doppler should be used to assess the vascular nature of tumors and can be extremely helpful in looking for ectopic pregnancies and may be of some use in assessing for ovarian torsion. While this is a talk on ultrasound, sometimes CT or MRI can be useful in looking for areas obscured by overlying air. With CT, we can assess for calcifications, fat, and gives us a large field of view for large masses. MRI is particularly helpful for uterine anomalies, looking at multiplanar imaging and perfusion characteristics. With children, of course, the drawbacks are cost, the need for sedation, and radiation exposure with CT. So let's start with the uterus. In the newborn period, you have a uterus that looks slightly pubertal in contour because of maternal hormonal stimulation. It may measure as much as 4 to 4.5 centimeters in length. This quickly decreases in size and becomes spade-like in configuration, with the fundus the same or smaller in size than the cervix. By 3 to 8 years of age, the uterus starts growing slowly in size, but typically you do not see an endometrial stripe. As the girl hits puberty, there's a rapid enlargement of the uterus. The fundus grows much larger than the cervix and descends deeper into the pelvis with a visible endometrial canal. So whenever we look at the uterus in a child, it's important to decide whether it's prepubertal or pubertal in configuration. So here is an 18-year-old with a very small uterus in which the cervix and uterus are similar in size. Following therapy, there's been an increase in the uterine thickness as compared to the cervix. There's not much to actually see in the vagina. It's hypoechogenic and tubular and looks fairly flat in the transverse plane. It should be relatively empty. In young infants, you may have anal atresia with a rectovaginal fistula, and you may see some echogenic material filling the vaginal canal in this scenario. When we look at the embryogenesis of the Müllerian ducts, there are two that are formed, and they form the fallopian tubes, uterus, cervix, and the upper 2/3 of the vagina. The ovaries come from the germ cells of the primitive yolk sac, while the lower third of the vagina is separate embryologic origin from the sinovaginal bulb. You can have complete agenesis of the Mullerian ducts, and that can result with complete absence of the uterus, and they're often associated with bladder and kidney abnormalities. Here we have an ectopic kidney. You can have failure of formation of one of the horns, and this results in a unicornuate uterus. If a rudimentary horn is present, it may be obstructed and present as a pelvic mass. With MR, CT, or VCUGs, you can help assess the rudimentary horn. Here we have a fluid-filled vaginal, obstructed vaginal canal that's compressing the other side of the vagina, and again associated with a single kidney, an absent kidney on the right and one kidney on the left. When there is failure of lateral fusion, you may have a spectrum of abnormalities. You can have 2 vaginal canals and Didelphys with 2 separate horns. You can have a Unicornuate uterus with a single vaginal canal and 2 endometria, or you can have a septated uterus. Ultrasound can help differentiate between the two. Here we have Didelphys with 2 separate horns. MRI and cystograms can help to separate whether there's a single vaginal canal or 2 vaginal canals, as we see here. When there is failure of vertical fusion, there's a separation between the upper 2/3 of the vagina and the lower 1/3 of the sinovaginal bulb. This can result in hydro or hematometrocolpos. Approximately 2/3 of these are due to an imperforate hymen, with 1/3 due to complete vaginal membrane. So metro means uterus, colpos is the vagina, and it can be distended by fluid, hydro, or echogenic blood, hemato. In the neonate, the mass looks fairly solid, and it will dilate the vagina and less so the uterus. When one encounters a mass at the level of the bladder, it's important to look at the superior aspect of the mass, and that's where you'll be able to identify the less distended uterus. In menarche, you may have a girl who's been complaining of intermittent pain and has had amenorrhea. By ultrasound, you again can see the vagina filled with blood as well as the uterus. It's important to look very carefully at the superior aspect of the mass, because at times the uterus is not distended at all and is a little nubbin at the superior aspect, but this helps to confirm the diagnosis. At times, by ultrasound, the findings may be somewhat confusing. Here again, we see an echogenic mass posterior to the bladder with some echogenic tubular structures which turn out to be blood-filled fallopian tubes. Here again on the longitudinal image, it's important to look carefully for where the uterus resides on top of the blood-filled vaginal canal. MRI at times can be helpful for more complex cases of vaginal atresia, and we can actually identify vaginal atresias as early as in the prenatal life. Here we have a fluid-filled structure with the cervix seated on top of this infant who had a hematometrocolpos from vaginal atresia. Rarely we can actually have invagination of the uterus. This actually looks like an intussusception, and indeed this was uterine inversion from a teratoma as a lead point. Luckily, uterine and vaginal tumors are fairly rare in pediatrics. Unfortunately, when present, they are typically malignant. They may present with pain, mass, vaginal discharge. They can actually protrude from the introitus. By ultrasound, they may look like a polypoid mass actually growing into the bladder. MRI at this time can be very helpful in looking at the extent with its large field of view. Endodermal sinus tumors typically present in infants between 8 and 15 months of age. Clear cell adenocarcinomas typically present after menarche. The most common is Sarcoma Botyroides. These typically present in children less than 3 years of age, and they originate from the urogenital sinus remnant. By ultrasound, Sarcoma Botyroides classically are called the cluster of grapes, where you see multiple cysts with some solid components. As mentioned, they can grow into the bladder and cause unusual bladder thickening, as well as grow into the labia and urethra. Here's a 2-year-old with a Sarcoma Botyroides mimicking a hematometrocolpos. The key here is the age of the patient. Remember, with hematometrocolpos, you should see either a mass in the newborn period or at menarche. So the 2 years of age was more consistent with a rhabdomyosarcoma. Let's move on to the ovary. You should be able to identify the pediatric ovary in up to 65% of newborns, and after the age of 2 in up to 80% of cases. Remember that it can be all along the embryologic course, so it can be as low down as the labia or as high up as the inferior border of the kidney. Post-puberty, the ovary tends to be lower in the pelvis, but in younger children, the ovary tends to be higher up than expected at the posterior fold of the broad ligament. Size changes again early on. It's fairly large due to maternal hormones. It'll decrease in size and then start increasing when puberty develops. As it increases at puberty, it can become as large as 18 centimeters cubed. Typically, physiologic cysts will be seen and are related to follicular maturation. In adolescence, you may see unstimulated follicles and pre-ovulatory follicles that measure less than 3 centimeters. And these can be normal. If it measures greater than 3 centimeters, we will call this a true ovarian cyst, and this can be seen prenatally in infancy as well as late childhood. If they are large and cause pain, the patient may present with mass, fever, irritability. They may turn on themselves or bleed or even rupture, and all of these can result in the pain the patient's feeling. By ultrasound, we look for a thin-walled anechoic structure measuring greater than 3 centimeters. Remember that ovarian masses in young infants and young girls often present as an abdominal mass. As the pelvis is quite small, any ovarian masses tend to move up into the abdomen and can mimic many abdominal masses. When we see these cysts measuring less than 4 to 5 centimeters, they typically involute in the neonatal period. And they may take up to 3 to 4 months to resolve, but typically can be asymptomatic. If they measure greater than 5 centimeters, however, there is a higher risk of torsion and they may need to be drained. Cysts can cause symptoms if they bleed, and they can simulate appendicitis. This is typically a diagnosis of exclusion. You may have the fishnet weave appearance of a complex cystic structure, but it's important to document resolution, as these may actually be a cystic neoplasm. So I have a question. What percentage of pediatric ovarian tumors are malignant? It turns out it's 35%. The most common are the benign cystic teratomas or cyst adenomas. And the malignant 35% include germ cell, stromal sex cord, and epithelial tumors. So cystic teratomas are about 40 to 50% of ovarian neoplasms in children, and they're typically benign. They come from the 3 germ cell layers, the ectoderm, mesoderm, and endoderm. The majority present at greater than 6 years of age, but remember that about 15% of these can be malignant. They may have symptoms from bleeding, torsion, rupture. By X-ray, you may see these strange calcifications in the pelvis. By ultrasound, they can be echogenic due to the fat, hair, and sebaceous material. They may have shadows, or they may simply be the tip of the iceberg with no real way of truly measuring the size of the fatty mass by ultrasound. When cystic, they're easier to identify and measure, and may have really no solid component associated with them. Here we have an echogenic structure. It's hard to know exactly how deep it goes into the pelvis, and this was a teratoma by CT. CT or MR at times can be helpful in assessing the size of the mass or calcification. And remember that 20% of teratomas can be bilateral, as in this case, where by ultrasound we identified one fatty teratoma, and yet the other one was actually separated, not a continuum of the same mass. As mentioned, a third of ovarian tumors are malignant. These are more commonly present post-puberty and often are hormonally active. By ultrasound, they are complex with thick septations, papillary projections. Typically, they're not just cystic. They'll have some soft tissue elements and may have secondary ascites and peritoneal implants. CT and MR in these cases are useful for staging and getting a large field of view, as often these masses can be greater than 10 centimeters at time of diagnosis. The most common malignant ovarian neoplasm in children is germ cell tumors. Stromal cell occur in 10% of cases, and epithelial carcinomas are fairly rare as well. With granulosa thecal cell tumors, they may have estrogen or androgen secretion. Typically by ultrasound, you'll see thick, irregular septations with solid components. They're fairly complex. Sertoli-Leydig cell tumors typically have androgen secretions, and they more commonly have a solid presentation, can also be quite large, and rarely have metastasis. When we have a teenager with pelvic pain, one of the differentials to consider is ovarian torsion. If there's Doppler demonstrated in the ovary, does this exclude the diagnosis? It's really not as simple as true or false. One should always consider adnexal torsion in the differential of a girl with acute or recurrent pelvic pain. The diagnosis is important to make, as you can salvage the ovary, but the symptoms unfortunately can be quite confusing, with intermittent episodes with nausea, vomiting, constipation. They may even have fever or pain. Remember that with adnexal torsion, it may be partial or complete. It may be secondary to an underlying mass in the ovary, or due to hydrosalpinx or a long mesoovarium. Adnexal torsion presentation can be very nonspecific and look different at different gestational ages. In the young infant, it may already be torted with calcifications and debris levels. Acutely, in a teenager, it may simply be a swollen ovary with multiple small follicles. It also depends on the underlying mass, whether it's a teratoma or a cystadenoma. So here at puberty, you may have simply a unilaterally enlarged solid ovary with peripheral follicles. And here we have a normal ovary on one side and a large, swollen, edematous ovary with multiple small follicles. Symptoms can be sudden or chronic. With acute symptoms, you may have a decrease in venous flow with an elevated resistive index. Chronically, you may have eventual decreased flow in the arteries. Finally, with arterial supply completely cut off, you may have gangrene, infection, and peritonitis. Unfortunately, with Doppler, if you see flow in the central portion of the ovary, that may help to rule out torsion. But in normal ovaries, flow may be difficult to document centrally, and there may be flow in partially twisted ovaries. And if there's a cyst, like a large teratoma, you may not actually see flow in the cystic component. So this limits the usefulness of differentiating cystic lesions from torsion in girls with acute pain. Here in a series by Stark et al., where they evaluated 14 torsions, 5 had no flow, 4 had peripheral flow, 3 actually had central flow. And in this series by Quillen et al., with looking at 42 adnexal lesions, there was no central flow in 3 torsions, but also no flow in 5 cystic lesions without torsion. And there was external flow in 2 torsions. Lastly, I'll just talk about the utility of ultrasound in looking at other reasons for pain. This is a 13-year-old with pelvic pain, and in this case we see an ovary with increased perfusion lateral to the ovary. It's important to consider the differential of tubovarian abscess, appendicitis, torsion, and ectopic pregnancies. In this case, the patient actually had an appendicitis adjacent to the ovary. But all 4 differentials need to be considered when looking at the ultrasound images presented. So when we're looking at the child with pelvic pain, it's important to include the differentials of intussusception, appendicitis, inflammatory bowel disease, infected urachus, omental torsion, Meckel's diverticulum, and even renal stones. So the presentation of acute gynecological emergencies can be quite variable and confusing. Understanding the differential, radiographic findings, and limitations of the exam are important in the accurate diagnosis of acute pelvic pain. Thank you.